One of the most important things you can do to set yourself up for medical necessity and success with an insurance audit is to have a rock solid diagnosis from the very beginning. And I have a really quick and easy way for you to create that rock solid diagnosis every single time. Hi, I'm Dr. Maelisa McCaffrey, author of the upcoming book, Stress-Free Documentation for Mental Health Clinicians. And today you are getting a sneak peek inside one of the lessons from my online course, Stress-Free Documentation for Clinicians. Now, I'm currently revamping this course, so I want to give you a little glimpse of what it might look like because this lesson is so good and so valuable, it will absolutely be staying in the next course. So you will get access to this and a lot more if you want to sign up. All right, let's check it out.
So one of the most important things you can do with assessment is learn the art of asking the right questions. So I really do think that diagnosis is an art because it's not quite as simple as just having someone fill out a Beck depression inventory and then assigning them a diagnosis, right? There are other things you need to do to substantiate that, and pretty much across the board, this is the case for psychiatrists as well as for us. You have to do a diagnostic interview. And with that, you need to be able to ask questions the right way. So we are going to talk about FIDO, which is an acronym that helps to cover the essential things that you need to ask questions about in order to create an accurate diagnosis. So if you can remember FIDO and what this stands for, then you will be able to remember to ask questions that will cover everything you need to create a diagnosis with any diagnosis inside the DSM. So first of all, frequency. So what is the frequency of symptoms? And if you think about this, this would be, for example, the difference between ADHD and having no diagnosis at all. So the symptoms in ADHD are common symptoms that every person on the planet deals with, right? But it's the frequency and the amount of symptoms that give it a diagnosis. So everybody forgets things, but does everybody forget things on a daily basis? No. Do some people on ADHD forget things on a daily basis? Yes. So that's what you're looking at. Literally asking people, how often does this happen? And helping them to break that down. And really this helps people identify why things are bothering them, as well as identify progress that they can make or how they want things to change. So through this assessment and diagnosis process, you're also helping people to establish what it is that they want from therapy. So it can be a really, really helpful process. It's not just so that you can give a diagnosis to an insurance company. So the I for FIDO is intensity. And that's for if you think about it, it could be the difference between ODD and conduct disorder. So, or it could also be the difference between bipolar 1 and bipolar 2, right? So the intensity of the symptoms are important to ask about. And you can use a variety of methods to ask people about this, but you want to be thinking about that. I guess a more common one that people might be dealing with is depression. And so obviously there are different levels, right? There's mild, moderate, and severe. And so you can ask people in an interview, so, you're feeling depressed now, could you rate that for me? What level would that be? And what has it been in the past? A lot of people with depression have dealt with it before. So you can ask them if, for example, maybe they were hospitalized at one time, but that was 10 years ago. You could say, well, what did you feel your depression was at, maybe a week before you were hospitalized, and where do you feel it's at now? And that can help both of you ascertain, what severity you might be dealing with in this moment. And again, really, really helpful for treatment and discussing with clients, not just for providing a diagnosis, but also necessary for providing a diagnosis. Then you want to look at duration. So for example, duration of symptoms could be different, the difference between mania and hypomania, because one of the criteria for that differentiation is how long people have been experiencing the symptoms. And it's often the differentiation between having no diagnosis and multiple disorders. So really looking at how long someone has been experiencing these symptoms is very, very important. And kind of related is asking them about onset. So when did the symptoms start how long have you been experiencing them? And these are a little different because duration, someone could be experiencing a depressed mood for 2 or 3 years, right? Someone could be experiencing a depressed mood for the last 2 months, but really the first time they felt depressed was 10 years ago. So looking at onset, and that's very different than someone who, for example, just manifested a panic attack for the very first time last month. So those are very different situations. So looking at onset would be perhaps the difference between acute stress disorder and PTSD. Really, the only difference there in those two disorders is the time frame and how long someone has experienced the symptoms. So asking about all of those things is very, very key. If you forget one of these aspects, then very often you will not be able to make an accurate diagnosis when you look at your DSM. So do remember that assessment is always an ongoing process for every client, just because you have a diagnosis now. And especially if your diagnosis is one of those time-limited ones, you want to schedule a time to check in again and document whether or not someone meets criteria for a different diagnosis after that time frame has passed. Now, there is some danger in diagnosis. For example, we want to make sure that we are not pathologizing what might be a cultural experience. Unfortunately, I have seen this myself as a reviewer more than once, and it's really, really sad, for example, to see that someone has given a teenager a diagnosis of, a psychotic diagnosis. I saw one with major depressive disorder with psychotic features when the child just reported that they were seeing their grandmother who had recently passed away. So that absolutely is not in the criteria for a psychotic symptom. It's a very common symptom. And it's much more common in certain cultures for people to see dead loved ones or think that they are seeing them. So really consider when you hear certain things, is this something that could be a cultural experience? Also, I've heard of African-American people being diagnosed with paranoia when actually, their quote-unquote paranoia was a legitimate concern. So really, really do think about that. And acknowledge that you might not understand someone's experience. And this is where it can be really important to consult. Remain as objective as possible whenever you are gathering data or documenting symptoms. They should really be in the client's own words. They should be very behaviorally based and very easy to understand. And this is where you are going to use your clinical judgment to determine why those symptoms may be occurring and to look at them as a whole together to determine a diagnosis. But the symptoms themselves should be very clear-cut and very much part of those five senses: seen, heard, smelled, etc.
Hope you found that information really helpful. I know it helped me tremendously, not only when I was a new clinician, but even after I had been diagnosing for years and knew my DSM really well. So if you want to check out stress-free documentation for mental health clinicians, the course or the book, go ahead and click the description below in this YouTube video. You'll have to click on the description and open up the details to get the links so that you can access either one of those. Happy writing!